Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Dear colleagues, today is the fifth episode of our discussion on pregnancy-specific liver diseases. Till now, we have understood in the first vlog the liver parameters change in the physiological change in the liver parameters in pregnancy. Then in the second vlog, we discussed our first case history of hyperemesis gravidarum. Then in the third vlog, we discussed the second case history, that of the intrahepatic cholestasis of pregnancy. In the last vlog, that was the fourth one, we discussed the pre-eclampsia and eclampsia patients. Today is the fifth vlog on this series, the fifth part, and we are discussing case history number 4. We are discussing case history number 4 in our discussion on pregnancy-specific liver diseases. This is a case history of 28 years old lady who is 34 weeks pregnant, and she presented with severe aches and pains, sudden weight gain, right upper quadrant pain, fatigue, nausea and vomiting, and jaundice. So 28 years old lady who is 34 weeks pregnant, and she has severe aches and pains. She had sudden weight gain, right upper quadrant pain, fatigue, nausea, vomiting, and jaundice. On examination, blood pressure 155 by 100, mild ascites and pedal edema. Her liver function tests revealed bilirubin 5.7 milligram, ALT 543, almost 10 times raised, AST 398, almost 9 times raised, alkaline phosphatase 200 raised, CBC hemoglobin 9.1 gram, platelet 98,000. Other labs, urea 70, mildly raised, creat 2.6, again raised, uric acid 7.6, RBS 90, PTINR 2.2 raised, D-dimers 450, urinary protein double plus, and electrolytes normal. So this is a 28 years old lady who is 34 weeks pregnant, and she presented with this jaundice, nausea, vomiting, right upper quadrant pain, and the BP high, mild ascites, pedal edema, raised ALT levels, hemoglobin a bit low, platelet bit low, urea creat mildly high, uric acid mildly high, RBS normal, PTINR prolonged, and urinary protein double plus protein. So the question is, what is the most probable diagnosis? So we write down with you, and how will you treat it? Let's see. The diagnosis here is HELLP syndrome, and you see the color coding. We discussed first case, hyperemesis gravidarum, and we saw it appears in first trimester. Then the intrahepatic cholestasis of pregnancy and pre-eclampsia and eclampsia, and we learned that it appears in second and third trimester. HELLP syndrome, it typically appears in the third trimester and even some postpartum period as well. HELLP syndrome means hemolysis, elevated liver enzymes more than 500, and low platelets. So this makes the word HELLP. Hemolysis, elevated liver enzymes, and low platelets. So these three components, they make the HELLP syndrome. And this is the diagnostic criteria for the HELLP syndrome. The diagnosis is often made on clinical grounds, and exclusion of other conditions like acute viral hepatitis A, B, E, hemolytic uremic syndrome, and thrombotic thrombocytopenic purpura, and acute fatty liver of pregnancy. So these are the four main conditions, and of course you need the help of a physician, the help of the hepatologist to diagnose if the patient is having these conditions. The classic hepatic lesion associated with HELLP syndrome is periportal or focal parenchymal necrosis. This is when you do the biopsy in these patients. HELLP syndrome occurs in 0.2 to 0.6% of all pregnancies and in 10 to 20% of patients with severe eclampsia. So if the patient has got eclampsia, pre-eclampsia, then the next complication or proceeding of that hypertensive liver disease is HELLP syndrome. It most commonly presents in the third trimester, and 20 to 30% of cases arise in the early postpartum period even. Although its symptoms are similar to pre-eclampsia and is one of the criteria of severe pre-eclampsia, it can develop without any signs or symptoms of pre-eclampsia. So this point should be noted. Signs of other organs involvement, including pulmonary edema, renal insufficiency, and cerebral or visual symptoms may be present. Inadequate vascular placental perfusion is the leading hypothesis in the etiology of pre-eclampsia, eclampsia, and HELLP syndrome. Uteroplacental ischemia leads to oxidative stress and release of anti-angiogenic factors, leading to generalized endothelial dysfunctions and thrombotic macroangiopathy with subsequent macroangiopathic hemolytic anemia and liver damage in patients with HELLP syndrome. This is the pathophysiological basis for this syndrome. HELLP syndrome can recur in subsequent pregnancies and is associated with high risk of complications, including fetal prematurity and intrauterine growth retardation. This is the classification for the HELLP syndrome. The Mississippi classification, it classifies HELLP syndrome into three classes. Class 1, when platelet is less than 50,000, AST, ALT more than 70, and lactate dehydrogenase more than 600. When patient has these three, it is called class 1. When platelets are 50 to 100,000, not that less, ALT is high, more than 70, LDH 100, it is called class 2. So the difference between a class 1 and class 2 is the platelet. In the class 1, platelet is less than 50, while in the class 2, it is 50 to 100,000. Then class 3 is platelets more than 100,000, AST, ALT more than 40, and LDH more than 600. So if we see these, the LDH is more than 600 in all these three, then the ALT, AST, if it's more than 40, then, and the platelets more than 100, then they call it class 2. When the platelets are less, the ALT is high, very high, then this is the class 2, and then the class 1. Then the Tennessee classification is complete syndrome. One is platelet less than 100,000, ALT, AST more than 70, and LDH more than 600. And incomplete, any one or two of the above. So the triad is that the platelets is less, AST, ALT is high, and lactic dehydrogenase is more than 600. HELLP syndrome management. What is the management? How you manage these patients? All patients should be managed by bed rest and control of hypertension. This is very important. All patients should receive intravenous magnesium sulfate to prevent seizures and cerebral changes during the intrapartum and postpartum period. Hepatic rupture is a rare but catastrophic complication of HELLP syndrome. It can be managed with hepatic artery ligation, hepatic packing or lobectomy, arterial embolization, liver transplantation. So this is a diagram with presenting patient having pre-eclampsia. There is decreased uterine placental blood flow leading to ischemia. There is increased placental oxidative stress and release of inflammatory products into maternal circulation. And then there is imbalance of anti and pro-angiogenic factors, and all these leads to the systemic maternal inflammatory response. There is activation of the coagulation and complement pathways, leading to the microvascular endothelial reactivation, leading to dysfunction and damage, and then this leads to RBCs are sphered and they flow through damaged vessels. Then there is the widespread platelet aggregation and agglutination, leading to decreased amount of platelets measurable on complete blood count, and there is micro thrombin in hepatic circulation. So this leads to then the microangiopathic hemolytic anemia, and lab findings indicate of hemolysis, and here it leads to low platelets. This leads to elevated enzymes. This also comes to elevated enzymes, and then you see a full HELLP syndrome with all the three components. So I end here. Till now, we have discussed the 4 case histories: the hyperemesis gravidarum, the intrahepatic cholestasis of pregnancy, then the pre-eclampsia and eclampsia, and now the HELLP syndrome. In the next vlog, we shall discuss the 5th case history, and then we shall discuss the last case history. So be with me. See you in the next vlog on discussion on the 5th case history.